Imagine waking up from, like, a routine dental surgery.
Hmm.
You're recovering on the sofa, but your jaw is just completely numb.
Yeah, which is pretty standard at first, right?
Exactly.
Yeah.
So you call your doctor and they tell you, it's perfectly normal, just give it some time. So you wait, weeks go by.
And you're still just waiting.
Right. But what you don't know, and what, frankly, too many patients aren't told, is that a silent 3-month countdown has literally just started.
Oh, absolutely.
And if you wait too long to get that numbness checked out, your brain will permanently rewire itself to make that numbness hurt forever.
It is a terrifying race against the clock.
Yeah.
And the tragic part is that the vast majority of people have absolutely no idea they're even running it.
Yeah.
We're dealing with an area of medicine that is just the absolute definition of diagnostic muddy waters.
Welcome to the deep dive. We have a massive stack of source material today. We've got clinical pathways, surgical risk assessments, NHS patient leaflets, and some really highly specialized dental surgery papers.
Heavy reading for sure.
Oh, yeah. But our mission today is to answer a very specific, slightly unnerving question. When is numbness after a medical treatment? Just, a normal part of the healing process.
And when is it a blaring red flag that requires your immediate attention?
Yes, exactly. Because whether you're prepping for a medical procedure right now, or maybe you're currently recovering from one, or you're just a curious learner fascinated by the bizarre wiring of the human nervous system.
Which it definitely is.
Right. This information is really the ultimate shortcut to being an empowered patient. The line between a successful, pain-free recovery and a permanent neurological injury can be incredibly thin.
It really is, yeah.
Okay, let's unpack this. Before we can identify what a dangerous red flag looks like, we have to establish the baseline. We need to know what normal looks like. So, set the stage for us. What exactly constitutes normal numbness right after a procedure?
Well, the most common form of intentional numbness comes from a nerve block. This involves an anesthetist using an ultrasound machine to visually locate a very specific nerve bundle in your body.
Like finding a specific wire in a wall.
Exactly like that.
Yeah.
And then they inject a local anesthetic fluid right next to it. That fluid physically bathes the nerve and temporarily blocks the sodium channels.
Those channels.
Yeah, it basically halts all electrical traffic from that specific area to your brain. So after that injection, the target baseline is for that area to feel warm, incredibly heavy, and totally numb for anywhere from 2 to 24 hours.
Wow. Okay, so during that window, you essentially have a dead weight attached to your body. I mean,
Yeah.
You can't use the limb properly at all.
You really can't. And we purposefully induce this profound localized paralysis because nerve blocks are just brilliant medical tools.
Right.
By shutting down the pain signal right at the source, patients have a much shorter recovery period in the hospital and they get their mobility back quicker. But most importantly, and this is key, it drastically reduces the need for heavy systemic painkillers like morphine.
Oh, right. Because morphine comes with a whole host of awful side effects that slow down recovery.
Yeah.
Like intense nausea, severe drowsiness.
Deep brain fog, all of that. By avoiding opioids, the body can focus purely on healing rather than, fighting off medication side effects.
That makes total sense.
Yeah.
Now, what about other procedures, like epidurals?
Right. So for procedures involving epidurals or spinal injections, which are routinely used for childbirth or major back surgery, the timeline stretches out a bit.
Okay.
Feeling tingling, heaviness, or a significantly reduced sensation in your legs or arms is completely expected for 24 to 72 hours.
Wow, up to 3 full days of weird sensations is still playing inside the bounds of normal.
Yeah, it really is. And as that chemical block finally begins to clear out of your tissue, the nerve starts firing again. So you're going to experience a lot of pins and needles.
Oh, I know that sensation well.
Yeah.
It feels exactly like when you fall asleep on your arm at a weird angle.
And I wake up in the middle of the night.
Yes. It's this sudden, intense, static electricity feeling. It's usually just an annoyance, but in a post-surgical context, that static electricity is actually a positive sign.
It is. It means the nerve is waking up and successfully reestablishing its connection to the brain. It's literally the sound of the system booting back up.
That's a great way to put it.
Furthermore, about 1 in 20 people will experience a slightly prolonged area of numbness or tingling that lasts beyond that 48-hour mark.
1 in 20. That's fairly common.
Yeah, but almost all of those minor lingering sensations resolve organically over the following days or weeks as the microscopic inflammation around the nerve settles down.
Okay, so if pins and needles are the sound of the nerve successfully waking up, what happens when the mute button stays stuck? Like, what are the warning signs that the nerve isn't just asleep, but is actually suffocating or suffering structural damage?
So this brings us to the acute immediate emergencies. These are the symptoms that demand immediate hospital contact
Right.
because they indicate something is mechanically compressing the nerve or the nervous system itself is under severe threat. The most critical red flags involve your core bodily functions. An inability to pass urine after several hours or a total loss of bowel or bladder control is an absolute drop everything emergency.
Oh, wow. That implies the nerves controlling your vital organs at the base of your spine are no longer communicating with your brain at all.
Precisely. Another major red flag is unexpected, severe muscle weakness. For example, if you're cleared to walk but suddenly can't bear any weight on your legs when you try to stand up.
That sounds terrifying.
Or you develop a condition called foot drop.
Foot drop.
Yeah, this is where the motor nerves are compromised to the point that you literally cannot lift the front part of your foot off the floor to take a normal step.
Gosh. I'm looking at this list of immediate red flags from the sources, and I want to ask about headaches.
Oh, the spinal headaches.
Yeah, it mentions severe or worsening headaches, but specifically highlights headaches that improve when you lie down. Why does your physical posture change a headache?
Right. So your brain and spinal cord are bathed in a protective cushion called cerebrospinal fluid. When a needle enters the spinal space, like during an epidural, it punctures the membrane holding that fluid in.
Okay, I'm following.
Sometimes that tiny puncture hole doesn't seal up right away, and fluid slowly leaks out. So when you stand up, gravity pulls the remaining fluid down, dropping the pressure inside your skull.
Oh, which causes an agonizing headache.
Exactly. And when you lie flat on your back, the pressure equalizes across your spinal column and your brain, and the headache basically vanishes.
That makes perfect mechanical sense. The sources also talk a lot about the danger of a hematoma pressing on the spinal cord or peripheral nerves.
Yes, that's a big one.
But I'm confused here. If I've just had, like, major knee surgery, my leg is naturally going to be incredibly swollen and bandaged up anyway.
Yeah.
How am I, as a patient sitting on my sofa, supposed to know the difference between normal postoperative swelling and a dangerous blood clot forming under the surface?
What's fascinating here is that your individual risk profile plays a massive role in answering that question. A dangerous hematoma isn't an equal opportunity complication.
What do you mean?
The risk skyrockets if you are taking blood-thinning medicines like warfarin or clopidogrel.
Why does a blood thinner change the equation so drastically?
Because a standard needle puncture usually scabs over internally within minutes. But if your blood isn't clotting normally due to medication, that tiny internal puncture can just keep leaking.
Oh, man.
Yeah, the blood has nowhere to go, so it pools, forming a large clot called a hematoma. It acts exactly like a rapidly expanding balloon trapped inside a closed space.
And it just squishes everything around it.
Yes. As it inflates, it puts immense mechanical pressure on the adjacent nerve, physically crushing the blood vessels that supply the nerve with oxygen.
It essentially starves the nerve to death.
It really does. It is a rare emergency, but if that expanding pressure isn't relieved quickly through urgent surgery to drain the blood, the nerve will die.
Which means permanent paralysis.
Exactly. Anyone on blood thinners needs to be hypervigilant about sudden increasing pain or worsening numbness that just doesn't fit the normal healing timeline.
You know, we tend to visualize nerve damage as an active injury, like a sharp needle grazing a nerve bundle, or a surgeon's scalpel making a millimeter miscalculation.
A lot of people picture that, yeah.
But looking through these surgical risk assessments, some of the most common causes of nerve damage have absolutely nothing to do with sharp instruments. They are completely passive.
It surprises a lot of patients to learn that the danger often comes from posture, pressure, and positioning.
Right.
Now, peripheral nerve damage across the body occurs uncommonly in less than 1 in 1,000 general anesthetics. But when it does occur, the most frequently reported injuries are to the ulnar nerve and the common peroneal nerve.
Okay, let's break those down. Start with the ulnar nerve.
So the ulnar nerve runs right near the surface of the skin at your elbow. It's what we commonly call the funny bone.
Right, which never feels funny when you hit it.
Exactly. Now, if your arm is resting heavily on a hard operating table or is strapped down securely for hours during a long surgery, that continuous, unrelenting pressure compresses the capillary blood vessels feeding the nerve.
And without blood.
The nerve slowly suffocates from a lack of oxygen. It's a condition called ischemia. This results in lasting numbness in your fourth and fifth fingers or a profound weakness in your grip.
Oh, wow. And what about the other one, the common peroneal nerve?
That nerve runs just below the knee on the outside of your leg, and it's incredibly vulnerable to compression. Pressure there from heavy surgical drapes, retractors, or simply the way the leg is positioned during a long
Can
procedure.
cause damage.
Yeah, it can cause numbness on the top of the foot and trigger that foot drop symptom we discussed earlier.
Here's where it gets really interesting. It's the profound irony of general anesthesia.
Oh, definitely.
The very chemical cocktail keeping you pain-free and allowing the surgeon to save your life simultaneously turns off your body's natural evolutionary alarm system.
It completely shuts it down.
Think about it. If we were awake on the sofa watching a movie, we'd naturally shift our weight the second our elbow or our knee started to ache. We adjust our posture subconsciously 100 times a day.
Right.
But under anesthesia, that protective reflex is completely silenced.
If we connect this to the bigger picture, that silent vulnerability extends well past the operating table. It follows you into the recovery room and right into your own home.
Because you're still numb.
Yes. When you're discharged, the nerve block is often still actively working. Patients must strictly follow instructions regarding wearing slings and how they position their limbs while resting.
You have to be super careful.
Until that block fully wears off and your internal alarms come back online, you are basically your own worst enemy.
Because you could, like, lean your completely numb arm against a boiling hot radiator and not feel a single thing until you literally smell burning tissue.
It sounds extreme, but yes. The NHS leaflets specifically warn about post-surgical risks like heel ischemia.
Heel ischemia.
Yeah, if you've had a sciatic nerve block for a major leg surgery, you might rest your heavy, immobile heel on the mattress for 12 hours straight.
And since you can't feel it.
Because you cannot feel the pressure building up, the blood flow to the skin and nerves of your heel is completely cut off by the sheer weight of your own leg. This can lead to severe, deep tissue ulceration.
Oh, that is brutal. So the numbness itself isn't what damages the nerve. The numbness simply prevents you from realizing you are currently destroying your own tissue.
Exactly.
You have to be the conscious, visual protector of your numb limb because the sensory protector is offline.
You have to look at your limb to know it's safe because you cannot trust what you feel.
Wow. Okay, so we've covered how physical pressure, a lack of oxygen, and internal bleeding can cause nerve damage.
Yeah.
But what happens when that post-surgical numbness doesn't just linger? What happens when it fundamentally changes its nature, transforming from a lack of sensation into chronic, debilitating pain?
Now we are crossing the threshold into neuropathic pain. This condition affects roughly 6 to 8% of the general population, often stemming from trauma, surgery, or underlying conditions like diabetes.
The clinical pathways make a very clear distinction here, and I really want to highlight it. Neuropathic pain is not inflammatory pain.
Right, it's totally different.
This isn't like a sprained ankle or a cut on your finger where the physical tissue is torn and inflamed, sending an appropriate warning signal to the brain.
Neuropathic pain is caused by a lesion or disease directly affecting the somatosensory nervous system.
Somatosensory system.
Yeah, it's basically your body's dedicated physical sensation network, the intricate wiring that allows you to feel touch, temperature, pressure, and pain. In neuropathic pain, the tissue might be perfectly healed, but the alarm system itself is broken and misfiring.
The symptoms described in these papers sound absolutely agonizing. Patients describe spontaneous shooting or burning pain. There are two specific clinical terms that really stand out: allodynia and hyperalgesia.
Those are the classic hallmarks, yeah.
What do those actually feel like to a patient?
Well, allodynia is a state where severe pain is produced by a completely innocuous, harmless stimulus.
Like what?
Imagine the light touch of a cotton bedsheet brushing against your leg as you try to sleep, or the feeling of a soft t-shirt resting on your shoulders, and it feels like a blowtorch is searing your skin.
Oh my God. A cotton bedsheet causing the sensation of a burn. The psychological toll of that must be immense.
It's devastating. And hyperalgesia is closely related. It's an increased, wildly exaggerated response to a stimulus that is normally only slightly uncomfortable.
Kind of like a minor bump.
Exactly. A tiny pinprick or a minor bump that should just be a mild annoyance feels like a deep, traumatic stab wound. These symptoms are notoriously worse at the end of the day, destroying sleep patterns and just devastating a patient's mental health.
And here's where the research takes a really dark turn, particularly regarding the timeline for treating this broken alarm system. The sources dive deep into dental surgery. specifically the extraction of third molars, which are commonly known as wisdom teeth.
Dental surgery provides a really stark warning about human psychology and medical complacency. The data reveals that 88% of injuries to the lingual nerve, that's the nerve supplying sensation to your tongue, resolve entirely on their own over time.
Which, I mean, on the surface sounds like a fantastic success rate.
It does, but it creates a massive systemic problem. It lulls doctors and dentists into a false sense of security.
Oh, I see.
Because almost 90% of these tongue nerves heal spontaneously, the clinical assumption becomes that all nerve injuries in the jaw will eventually recover if we just prescribe patience.
But the sources show that's an incredibly dangerous misconception. Injuries to the inferior alveolar nerve, the nerve bundle that runs through your lower jawbone and supplies sensation to your lower teeth and chin, do not share that high recovery rate.
No, they don't. Those injuries often end up being permanent.
Right. And because of that false sense of security you mentioned, the medical system is fundamentally failing these specific patients. The dental papers highlight a massive flaw. Patients with these trigeminal nerve injuries wait an average of 16 months for surgical nerve exploration to see what went wrong.
16 months is a lifetime in nerve injury time.
Right. So if I've had a wisdom tooth pulled and my chin is still numb or intensely burning after 2 months, I shouldn't just let my dentist tell me give it more time.
This raises an important question about how fiercely patients need to advocate for themselves. And the absolute scientifically backed answer is no. You do not just keep waiting.
You have to push back.
The clinical guidelines state very clearly that the persistence of nerve symptoms beyond 3 months indicates that a spontaneous return to normal function is highly unlikely.
3 months is the critical make-or-break window.
After 3 months, permanent central and peripheral changes occur in the nervous system. This is a process called central sensitization.
Sensitization.
Yeah. The peripheral nerve gets so used to sending these distorted, panicked signals, and the brain gets so used to receiving them that the pathway becomes physically hardwired.
It's like walking across a grassy field.
Yeah.
If you walk across it once or twice, the grass just bounces back.
Yeah.
But if you march along that exact same route every single day for 3 months, you wear a permanent dirt path deep into the ground. The grass won't grow back. The brain does the exact same thing with these pain signals. It carves a permanent dirt path of agony.
That is the perfect way to visualize neuroplasticity. The brain learns to be in pain. And after that 3-month mark, once that dirt path is carved, surgical intervention to fix the original physical nerve damage is highly unlikely to be successful.
Because the pain is now living in the brain circuitry, not just the jaw.
Exactly.
If the average wait time is 16 months, the window for a surgical fix has been slammed shut, locked, and bolted for over a year. A specialist referral must happen before 8 to 12 weeks to prevent those permanent neural changes.
And once that window closes and the pain becomes hardwired, the treatment strategy has to shift entirely. You can't just take normal anti-inflammatory painkillers like paracetamol or ibuprofen.
They won't work.
They won't touch neuropathic pain because there is no inflammation to reduce.
It's an electrical storm, not a swollen joint.
Doctors have to prescribe medications that physically alter the electrical activity within the central nervous system. The first-line treatments listed in the pathways are amitriptyline or duloxetine.
I recognize those names. Those are common antidepressants.
They are, but we use them in much lower doses for nerve pain. They work by altering how neurotransmitters carry signals across the gaps between nerves in the brain and spinal cord, essentially dampening the transmission of the pain signal.
And if those fail?
If those fail, the second-line treatments include gabapentin or pregabalin. These are medications traditionally designed and used for epilepsy.
Anti-seizure medication for nerve pain.
Well, a seizure is a massive, uncontrolled electrical storm in the brain. Neuropathic pain is like a localized electrical storm in a single nerve pathway.
Ah, I see.
Gabapentin works by blocking specific calcium channels in the nerve cells, which slows down the rapid-fire electrical impulses. It forces the screaming nerve to calm down. But these medications come with heavy side effects like dizziness and weight gain, and they do not work for everyone.
Which, again, just highlights why early intervention before that 3-month window is so critical.
Oh, absolutely.
Okay, let's pull all of this together. Numbness is a brilliant, necessary medical tool that allows us to undergo life-saving procedures without trauma, but you must respect its strict timelines. You have to know the immediate red flags.
If you experience an inability to pass urine, loss of bowel control, sudden severe muscle weakness like foot drop, or severe back pain and headaches that drastically change when you change posture, seek emergency medical help immediately.
And if you're on blood thinners, You are at a significantly higher risk for an expanding hematoma crushing a nerve, so you need to be watching your surgical site like a hawk. Furthermore, when you are numb, you have to be the conscious guardian of your body.
Your natural alarms are turned off.
Right. Don't rest your heel on a hard mattress for 12 hours, and don't lean your numb arm against a hot radiator.
And above all else, never ignore numbness that lingers beyond a few weeks, and certainly never ignore numbness that transforms into a burning pain from a light touch.
This is entirely about patient empowerment. Use this knowledge to advocate for yourself. If you are crossing that 8 to 12-week threshold after a procedure and things still feel wrong, do not let anyone brush you off.
No, absolutely not.
Do not let them dismiss your lingering symptoms as just normal healing. Demand that specialist referral before the 3-month window closes and your brain carves that permanent path.
It's your body. You have to protect it.
So what does this all mean? We started out talking about hitting the mute button on the stereo of your nervous system, but learning about how quickly the nervous system adapts and how it permanently rewires itself when that mute button gets stuck. Well, it leaves me with a thought I really can't shake.
What's that?
If permanent, irreversible changes occur in our central nervous system after just 3 months of altered nerve input from a minor surgery, if our brains can literally relearn how to feel reality that quickly, how much of our perceived everyday reality is actually objectively real?
Oh, wow.
Right. Or is everything we feel, everything we think is solid, true, and permanent, actually just a fragile, temporary construct built entirely by whatever specific electrical signals our nerves happen to be sending us right now?
That is a deep thought.
Something to think about the next time your foot falls asleep.
Yeah.